So let's talk about medication management in ADHD. What are your thoughts on how we use objective measures for that?
Well, it's always a question. We know from the MTA study from 1999 that medication effectiveness is dose related. So finding the right dose of the right medicine is the key in managing ADHD. But how do you get to the right dose? If you have a hard time getting feedback sometimes. In the clinical situation in clinic, you often have parents or grandparents that don't see the child during the bulk of medication effect, but a couple of days a week. Sometimes you can get teacher rating scales, but having an objective measure that is standardized can be extremely helpful in optimizing dose of medication.
Yeah, and I add to that. I mean, there's a lot of different medications, even within the same type, and what you don't really know is which is going to be the effective medication for that person and the effective dose. And a good practitioner will always start at a lower dose.
Yes.
And titrate up appropriately. And we always say start low and go slow, but do go. And for stimulants, the good thing about them is very quickly how well that dose works for you. So you don't have to wait weeks to months before you go up on it. And I tell all my patients that don't be shocked if a low dose works, but don't be bummed if the low dose doesn't work. It's
Absolutely.
just a low dose. Have some patience, and we're going to get there together. And I think, and then to the point is, when is it enough? And I think that's where you can add your objective measures before you start, and then after to see, has there been enough change to say we're where we want to be at this point.
And with regard to parents being part, because as a pediatrician, the parents are almost uniformly afraid of these medicines, with good reason, because they were misused to sit little boys still and quiet when back in the days of Adderall and Ritalin. And so they have justifiable concerns about dose of medication. But the bottom line is, even in children, the dose is not determined by age or size, weight, severity of symptoms, what the testing shows, what Dr. Wiley thinks. It's definitely based on that individual's metabolism of that molecule, that particular medication, and the time release formulation, how the medicine goes into the bloodstream. And different kids and adults metabolize at different rates, and that's why it's so very specific to each individual.
Yeah, and how long it's in the effective zone. Like
Absolutely.
It's just medication's going to last me 12 hours. I said, well, that dose might not, because it's only in the effective zone for a little bit, because that's not the right dose. And they're always looking for like those kind of answers, and you say, well, we have to wait and see. Yeah. And the other thing I always reassure them about is like, because sometimes there are side effects. If there's something we really don't like and we can't get past, we stop the medication, and by the end of the day, the kid is back to where they were before. Yeah. So, and I say that's how quickly they'll rebound, and I think that reassures a lot of parents about it. And I think it will ultimately help them, and you try to partner with them and the kid, and if it's the adult, with the adult, about we're a team, we're going to do this together. We want to eliminate the difficult things so you can be more of you and not not like a limited version of yourself.
No parent wants a robotic zombie version of their child to replace their ADHD behaving child. So the key is to assure the parent that that's not what we're trying to do.
Changing the child, but helping them to be the best version of themselves.
Treating the medical condition and leaving the child alone is a phrase that I use a lot. No zombies. So if your child becomes flat or has other significant side effects, like a significant decrease in appetite or and others, then that's too much medicine. I find, and David, I'm interested in how you approach this, but there are three things that I tell parents to look out for because every parent is concerned about over-medication, right? But the studies show that most kids actually don't have enough medicine, especially in a community medical setting. So there are three indications that it's not enough medicine, at least three. It's just not effective enough. The teacher and the parent are not noticing that the symptoms are well controlled. It's effective for a number of hours, as David was saying, But at the afternoon, it loses effect before an 8-hour window if it's an extended release medicine, and especially if that loss of symptom control is associated with a rebound, either emotional reaction or irritable reaction, sort of what we call the crash. And the analogy I use is you cleared the tree line, but as the medicine was being metabolized out of the system, you hit a power line on the way down. And parents really resonate with that because that is what it feels like to them. And very often, if they're not having morning blunting, going up on the dose will lead to a safer landing. Is that your experience as well?
Yeah, I mean, definitely. And I think, back to it, like, we don't want to create little zombies. We don't want these little, sometimes it's, again, that specific formulation of that specific medication.
Exactly.
And you have other choices. And it's just, we're not there yet where I can do a mouth swab in my clinic and get some genetic information saying, oh, this is going to be a kid that will respond to Concerta in this range, and people always say, then aren't you treating your kid like a guinea pig? And the answer is no, because we know the medication works. I just don't know what dose it's going to work yet. And there are times you got to try more than one, and that's sometimes hard for parents, and it's frustrating because I want to make them better the first time, and so.
And it would be the same. My background is in chronic disease management. I only came to ADHD management in the second half of my career, and I tell parents all the time, this is like starting insulin in a new diabetic. I know generally that insulin will help and how long the different formulations are supposed to last, but finding a regimen that gets the blood sugar normal all day and all night is a challenge. And you have to be aware that there are probably going to be some low blood sugars. Yeah. Mm-hmm. So there are going to be some days with side effects as we optimize the medication. Yeah. But the long-term benefit of medication management is so extraordinary that it's worth those frustrations that David is talking about.
So these sound like some of the challenges you guys face while trying to titrate ADHD, right? Is making sure you find the right dosage that the patient's responsive to without feeling the frustrations of the crash or overcorrecting where they're getting a flat affect.
And if they're having side effects, they're usually front-loaded on the first couple of days of medication. So we do tend to say, stick with it unless it's really significant, the side effects. Mm-hmm. Stick with it for 3 to 5 days, or maybe even a week, because side effects do tend to go down with time.
I actually recently started calling them adjustment effects.
Adjustment effects is a great word.
Because a side effect is persistent. And I always say, like, I can't guarantee you not something that's going to happen or that there's going to be a side effect. And I always say, like, if you give them the kid the medication, and let's just say there was an underlying anxiety disorder, and an hour later they're off the chart, that's pretty likely that the medication is stimulating the anxiety. Whereas if that happens, like you said, at the end of the day, well, that's the crash. So actually, they don't have enough of it. So that's where the art comes in, and I think that's where. And there are some kids that you can give a long acting in the morning, but every time you try to go up on that long acting, it's a little much, and then you got to be flexible. Like, okay, then I can give a short acting booster in the afternoon just to carry them a little longer, and that's where. You have to be flexible. You're treating the person. You're not treating a study. You're not, and every kid's different. And it makes it hard for us because, I can have 100 kids with ADHD and they might all have different, like most of them probably won't have the exact same regimen.
Yeah.
We often hear from parents, my friend's child did well on this medicine, or my nephew did well on this medicine. And it's you have to be kind of creative to find a way to say that's wonderful. It has nothing to do with your child whatsoever.
Yes.
Even a brother and sister might be in the same gene pool, but at opposite ends.